Welcome everyone to another virtual shadowing session at Hearts for Health. Today we're joined by Megan. She is a PA practicing colorectal surgery in the UK. So we'll get to see how medicine is practiced in a different country. I think we've had a few international speakers in Canada, maybe one or two in the UK already, and also one in India. So it's great to have you join us today, Megan. I do have a couple reminders for those listening, especially if you're new to our program. Towards the end of each of these sessions, we have a Q&A. So if you have any questions about what Megan talks about or generally about her specialty, what it is to be a PA, any of those, feel free to type them in the chat and we'll get around to those at the end of the session towards the last 20 minutes of the hour. And also, if you'd like to stay updated with more shadowing sessions, we do have these on either Mondays and Thursdays. We will have one coming up in December on the 7th, and we will continue to have these shadowing sessions going into the next spring, into the new year. So there's two ways you can go about staying tuned with more. We either have our Instagram page, where I'm sure a lot of y'all have seen our flyer that we posted a couple of days ago, or our email listserv, which is another way that you can get that flyer. It's a weekly listserv, but we do include some more opportunities to do with volunteering programs on that listserv on a more consistent basis. You will still see that on our Instagram page. We do post applications for our internship, which is live, and that will actually be something that closes on December 1st. So if you want to join the team for a semester or longer, you can join through that internship application. We do have quite a few volunteering programs that go around at this time of year. So you'll see, if we haven't already sent them out for the majority of our programs, you'll see them sooner or later within this next few weeks for non-clinical and clinical volunteering. Some of it is virtual, some of it is in person. It really just depends. And you can get all that information on our website, hearts4health.org. With that said, though, those are all the reminders I have for y'all. If you have any questions about what I said to do with virtual shadowing or our other programs, feel free to email us. Our email is community@hearts4health.org, and we can answer any questions that y'all have. But I don't want to take up too much time. So Megan, feel free to take it away.
Great. Thank you so much, Michael. So, hello, and thank you to Hearts for Health for having me. So like Michael said, my name is Megan. I'm a US trained physician assistant, and I've worked in the UK for the last 7 years. I thought I'd talk a little bit about my background and what I do in colorectal surgery, and then we talk about a couple recent cases. And then we'll have time for questions. And if you have any questions about working colorectal surgery, or in GYN oncology, which is my previous life, or applying to PA school, or what it's like to work in the UK, please put it in. If I can't see them, then Michael will help me because this is my first time doing this. So I've been a PA for 13 years. I have a bachelor's degree from University of North Carolina in psychology. And I found the PA route when I was about a senior in college. I knew I wanted to work in healthcare, but I didn't know where. I was planning on graduating with my bachelor's degree and then going into like an accelerated nursing program and then becoming a nurse practitioner. And then my mom, who's a nurse, first told me about the PA profession. And so I went and shadowed her primary care provider, who was a family medicine physician assistant. And I really loved it and loved the kind of work she did. And also practically it made sense because then I could just work and go to PA school without having to get the degrees in the middle as well. And that's what I did. I worked as a home health aide and a CNA and a medical assistant in pediatrics. And then I went to PA school at Nova Southeastern University in South Florida. And I graduated in 2010. So I've been a PA for 13 years. And I worked in GYN oncology for the first 11 years of my practice in the US. And then I moved to the UK in 2016 as a part of a program. The PA role is quite American, as you all will know, but is starting to grow in other countries. So I moved over with a program that was kind of expanding the PA role in the UK. They have PAs working, but more in primary care than in hospital secondary care specialties. So recruiting kind of experienced PAs to come work in the National Health Service, which is the government run health system of the UK, in hospitals that didn't have PAs to see if they liked the role, if they were interested in expanding it. And it was just supposed to be for 2 years, but I really liked it. And so we stuck around. And then when we got dual citizenship, we thought we might want to move to Scotland because we always liked going on vacation there. And so a job came up in colorectal surgery. And it was my first time ever switching specialties in 13 years, which, as you'll know, is a kind of a perk of the PA profession. That was scary. I figured it was kind of below the belt, so it was close enough to my background in gynecology where I could put some of it to good use. And yeah, and I've been here for the last 2 years. And what I really like about working in colorectal surgery is true about GYN oncology as well. Why I think surgical specialties are great roles for PAs is it's a good mix of different areas you get to work in. So, in my role in colorectal surgery, I run independent clinics like the kind of cancer diagnostic clinic. So, we'll talk about a case when I get to that. But if people have kind of symptoms of colorectal cancer, I see them and do the workup and manage the investigations. And then if they're diagnosed with the colorectal cancer, then they see the surgeon. Um, I also assist in surgery. I'm the main kind of robotic assistant for the robotic colorectal surgery. So that's interesting. And as surgical assistant goes, it's kind of interesting and there's good problem solving because in robotic surgery, the robot drives up to the patient and you connect it to different ports that are attached on the patient's abdomen, and then the surgeon is at a console on the side of the room. So the kind of problem solving and troubleshooting that in kind of laparoscopic surgery the surgeon will be helping you with, in robotic surgery you're kind of the main person at the bedside figuring things out and communicating to the surgeon who's across the room. So that's an interesting role. And then I also do a hospital ward-based management of our colorectal patients. And as what I enjoy also about switching to colorectal surgery is all the colorectal surgeons are also general surgeons. So part of my job is also managing the emergency general surgery patients. And so since I work at a kind of smaller hospital that draws from a big rural area, it's also the trauma hospital. So we get a fair amount of traumas as well as general surgery complaints. So even though we work in colorectal surgery, we'll manage patients with head traumas and car crashes and chest tubes and people have had their gallbladder out for cholecystitis, people have had their appendix out for appendicitis, and so there's always something new to be had in general surgery for sure. So it's a good specialty for someone that gets bored, kind of like ER. And what I like about another thing I like about colorectal surgery that also is true for GYN oncology is it's a combination of getting to assist in surgeries and do surgical management, but since they're both oncology specialties taking care of patients who might have or do have cancer, there's also good opportunities to connect with patients and counsel them through a time that is kind of difficult. And it can be helpful to have someone like a PA who is there through these different parts of their kind of journey as a patient to help guide them through, and can be kind of a familiar face of when you see them in clinic and then you see them in surgery, then you see them in the hospital afterwards. And so that makes you feel good if when you're able to provide patients reassurance because they remember you from these other parts of their path. And another part I like about working in a surgical specialty is it's definitely different people have different preferences. It's a smaller range of presentations than you would see in, say, working in the ER or working in family medicine, but you get to become quite an expert on these kind of specialized conditions, which is someone that's always worked in specialties I really enjoy. That might not be everyone's bag. And but I really enjoy developing kind of specialist skills and specialist knowledge in a kind of specialty team area, and then being able to use that knowledge in different areas of practice of outpatients, inpatients, surgery, um, whereas more generalist specialties um, will see a larger range of patients, will have a bigger areas, bigger ranges of things they'll diagnose and things they work up on, but may be a bit more limited in the areas they work. For instance, if you work in the ER, you work in the ER and maybe like urgent care, but you're primarily placed there. And if you work in family medicine, you work in outpatients. Um, if you're a hospitalist, you work in the hospital on the wards. And so the generalists will, I think, have probably more variety from medical diagnosis, but maybe a little less variety in kind of, I don't know how you'd call it, but geographic practice of like where you might go on any given day. So that's something to think about if you're thinking about becoming a PA and what you might be interested in practicing in the future. And great. So, and maybe talk a little bit about things that are different from the US and the UK. The PA role is what I do in a given day in the US and the UK is quite similar. Um, Both in the US and the UK, I do the hospital ward round in the morning and I see patients in clinic. Um, in both cases, I see the kind of more straightforward ones and the diagnostics, and then the surgeons see the complex ones and the patients after they've been diagnosed with a cancer, and they counsel them through surgery or what the treatment will be, and as well as first assisting in surgery. The difference in the UK is because since the profession is much newer, the kind of rights and privileges that we have in the US, they're still kind of ongoing in the UK. So currently, PAs can't prescribe medications, which includes prescribing radiation. So you can't order X-rays or CTs because you're they consider prescribing radiation to have those tests. And that is because in the UK, PAs, physician associates in the UK, are not yet regulated. They are becoming regulated by the GMC, the General Medical Council, which is kind of like the UK-wide version of a state's medical board, who regulates us and physicians per state in the US. And that was supposed to happen before COVID, but things get delayed. And so I'm very hopeful that that will change, because that is a limit to your practice, and I think probably a limit a bit to the growth of the PA profession, where because PAs can't prescribe in the UK, and there are other kind of advanced practice provider roles that can. But I'm hoping that will change in the next 5 years or so. And then beyond that, the main differences is that come from, in the UK, it's nationalized healthcare, so it's government-run healthcare, socialized medicine, and the differences kind of derive from that rather than like my practice as a PA. So the good things of it that I like are it's completely nationalized. No one pays for anything at the time you get it. So no one gets a hospital bill, no one gets a doctor's bill, no one gets a bill from surgery. There are no bills for anything. It just, you pay for it in your taxes, like in the US, we pay for, Medicare and Medicaid. And so that's really nice, because it can be, frustrating in the US when you know what's the right treatment to give, but you're limited by the patient's insurance, of what their insurance will cover or their lack of insurance coverage. And so that was very nice that everyone is able to get the same thing and no one has to pay a bill because of it. So that's nice. Some of the things that are challenging in the UK in the NHS is because it is government run. It is, quite, budget conscious. So um, they'll pay money for things that are direct for patient care and patient survival, but they will not spend money on things that aren't directly tied to that. So there are like ward rooms where there'll be like 4 or 6 patients to a room, which I had never seen before till coming to the UK. And certainly there's no doctor's lounge where you're getting free food or free anything. And then the hospitals are older and the IT is much older. Um, and and it is what I found is there's sometimes, which I'll talk a little bit about in my case as well, um, because there's these differences in the health systems. There's a little bit of difference in motivation uh, that comes into play when you make like national guidelines. So, for instance, because I've worked in the UK, I was brushing up on what like the US colorectal cancer screening guidelines are to make sure I'm not telling you guys false information. And they offer not the US Preventative Health Task Force offers a few different options and doesn't really say which one is best. Um, and whereas the UK stopped doing screening colonoscopies and only do FIT, with a stool testing for microscopic amounts of blood. Um, and the reason, kind of one part of the reason probably for each country is the UK's motivation is to save money, so colonoscopies are very expensive. Um, Whereas if you can do that with a test that they don't need to come to the hospital for, that they can just mail out to patients, that saves a lot of money. Versus in the US, where it's private, and colonoscopies make a lot of money, that takes into account when recommendations are made as well. So, not saying that either is wrong or either is right, but it's just something I've noticed working in two systems that's made me, um, cognizant of how healthcare motivations can affect things like screening, and to kind of look into the research and things for myself to um, see where more things are coming from. And okay, so let's talk about a couple cases. So I had an interesting case this week, kind of a bit of a sad case, unfortunately, last week, excuse me. And I thought it would be a good one to talk about because my background's in gynecology and now I work in colorectal surgery. So this was a um, young woman for cancer care. She's 42 and she presented to the ER with months of abdominal bloating and pain. And she'd been kind of going to the primary care provider and they'd been kind of putting her off, saying, oh, it's probably IBS and things like that. Um, and so she gets an ultrasound in the ER that shows a big pelvic mass. So it's 20 centimeters, so this size. So she gets admitted to the gynecology floor. And it shows this ovarian mass and fluid um, in the abdomen, which is called ascites, and that can be, when you have a mass and fluid in the stomach, can be a sign of ovarian cancer. So she got CT staging, where they do CTs of their chest and belly and pelvis to see if there's any spread of cancer anywhere else before they decide her surgery. And on these CTs, they found another tumor in her sigmoid colon. And so that's why the my team got involved in the colorectal surgery team. And so she had a colonoscopy, a camera test through the rectum that goes through the colon. and they took biopsies of the tumor and they found that it was colorectal cancer. And so now we have this big mass, and we know that we have a colon cancer. And so, and she is a young woman, so obviously we want to do the most that we can. And having this big mass is quite uncomfortable for her, and she's a slim lady. So last week we did a joint surgery with the colorectal surgeons and the GYN oncologists, and took out this mass and did a ovarian debulking surgery, like she had an ovarian cancer, which is both ovaries come out and the uterus and cervix, the opening of the uterus comes out, as well as some of the omentum, the fatty apron that lays over the tummy, because that is a common site of spread for ovarian cancers. And then we took out her sigmoid colon, and using staplers, staple each side of it that they staple, and then it slices in between. So you cut the segment of colon off, and then using another gun that goes through the rectum, and it has a little anvil that pokes inside the bowel, the one that you're leaving behind, and then you put the other little part of the anvil into the other part of the bowel, and it staples them together. And so she was able to be rejoined and didn't need a stoma, like a bag that the stool comes from. So that was good news. And it turns out that the mass was what we call a Krukenberg tumor, which is when, so she didn't have an ovarian cancer, she had a sigmoid cancer that had metastasized to the ovary. And that is sometimes how colorectal cancers or upper GI cancers are found, when they've spread to somewhere else and made a mass. So they're still waiting on the final pathology to the lab, so they take all these parts out and send them to the lab, where they cut them up in tiny sections, look at them under their microscope, and then tell the doctors what stage it is. So what grade the tumor is, does it look the most like normal cells or the least like normal cells? The least it looks like normal cells, the usually more aggressive the tumor is, as well as what organs the cancer was involved in and where it spread to. And unfortunately, just being in the ovary, she'll likely need chemotherapy afterwards, but are still waiting for the final tests to plan that. And I thought this was a interesting case because it is just something to keep in mind of your practice, of just because there's a mass in the GYN area doesn't mean that it's a gynecology problem, and vice versa. You always keep in the back of your mind, even if you have a diagnosis that it could be, to always keep updating your kind of differential diagnosis, because there's always a potentially better answer once you have more information. So to not get kind of locked into the information that you've found already. And then the other case that I thought I would talk about is a common way that we diagnose colorectal cancers. And if it's possible, I would love to ask in the chat if people have any ideas of the kind of symptoms you might have if you had a cancer in your colon and didn't know about it. Is that possible, Michael?
Yeah, might just take a minute or two for responses to roll in, but while we're here, we can maybe have a quick mini Q&A while we wait for those responses to roll in. And at the very beginning, you mentioned that you had a bachelor's in psychology, right? Before you went on to PA school. Did anything that you learned in undergrad carry over to PA school? Did it make the process a little easier in terms of your major?
Well, you can have any degree going into PA school, and it kind of helps if it's a science S degree just because of the classes that you need to take. And I loved my psychology classes. I love my psychology degree. So I would do it again in a heartbeat because what I did not enjoy are any of my prerequisite classes. And if I were just taking all of those, I think I would have um I would have gone nuts and just, you know, total props to these students who are getting degrees in like biochemistry and immunology. And, I was like, power to you, but I wouldn't have been able to do it. Really, I really enjoyed my psychology classes. And I really enjoyed my psychology degree. And, and it kind of like, I don't know, kept me sane with these other classes that were that were real. I'm not that not that it's easy, but I feel like the prerequisite classes are particularly difficult. Um, and so I really enjoyed my degree, and I think when you're taking hard and challenging classes, I think it's important that you're taking classes that you like as well. It makes it a lot more tolerable. And it helped. It helped some with certainly with the like psychiatry portion of PA school. Because you're taking abnormal psychology, I was already familiar with a lot of the conditions. Um, it also helped learning about substance abuse. I had taken a course on drugs. It was like pharmacology, including like psychedelic drugs. That was just very interesting. But that did help with the in kind of pharmacology and substance abuse portions. Um, Probably what would have like helped the most is just like a million anatomy and physiology classes. But if I was doing it all over again, I would do a psychology degree again, just because it's always been my first love. I still enjoy it.
Yeah, there are a lot of students out there that go through the psychology route, but they still might be pre-med or pre-PA.
Yes, yeah, I had several classmates in my psych classes who are pre-med and are now residents. And yeah, definitely. And at least at my university, you could get psychology as a BA or a BS. So I graduated with it as a BS, doing some additional research and some additional courses. um, and so for students who are interested in using a psychology degree and then becoming a PA or becoming an MD or DO, getting the BS if there's an option for that, I think is a good idea or something to think about at least.
Yeah, definitely. Because it's on the more science side, it would definitely incorporate the prereqs a little easier. I do have
Yeah.
we have one response on the question: loose stools or chronic diarrhea. Those are two.
Yes. Yeah. And we have certain criteria for our kind of like cancer diagnostic clinics. And the top one is we call it altered bowel habit. So your bowels changing for 4 weeks or greater, particularly to loose stool. So so that's great. A what they're looking for in the bowel screening program, or in so in the UK and then in the US they do this test where um but they do the screen coloscopies as well, where they give you it's like a little card that you take stool on and it tests for DNA of blood in the stool. So kind of microscopic amounts of blood in the stool. And why, and if that is quite positive, why that is concerning for a bowel cancer is when there's blood in the stool. One of the things that can cause bleeding is like a tumor that's growing on the inside of the colon. And if you could imagine, like you had like a tumor on your hand or something and we're rubbing it, like you could imagine how it might be irritated and bleed. And so having that in your colon, and your colon is, peristalsing, squeezing, and the stool and stuff is, rubbing against it. Um, you could imagine how that would cause it to bleed. So sometimes people have blood in their stool. Um, Kind of more red blood could be indicative of a colon or rectal or anal cancer. And then sometimes black blood that looks like old digested blood or something like coffee grounds could be indicative of bleeding from your upper GI tract, like your esophagus or your stomach. Um, but sometimes when there's a cancer, it causes a small amount of bleeding that we can't even see with our eyes. So that's what these stool tests look for. And another reason that, other than having a stool test that's positive for blood, that you might do a test like a colonoscopy is if they have anemia, if their blood count is low and you don't know why. So just like about why the blood in the stool would be positive, um, if you have an iron deficiency anemia, and one of the biggest causes of iron deficiency anemia is blood loss. So, for instance, women that have very heavy periods or often chronically have iron deficiency anemia. And so, if the patient is getting, routine labs or something at their primary care doctor and has an iron deficiency anemia and doesn't have heavy periods, then they would want to do testing and figure out why. And one of the reasons why could be a cancer of the colon or of the esophagus or stomach, and that's causing some bleeding that's just trickling out enough to make your blood count low, but not enough for you to see it with your eyes. And so when we get referrals for um, iron deficiency anemia of unknown cause, then they get investigations from the top end, like a gastroscopy that goes in the mouth and looks at the esophagus and stomach, as well as a either colonoscopy, the camera that goes through the anus and rectum up the entire colon, or a colon capsule endoscopy where you swallow a tablet-sized video camera that has two cameras on each side and gets activated by the acid in your stomach. And it's pretty cool technology. And then you wear this like belt, and it takes thousands of pictures of your colon all the way down, and they get transmitted to this belt and then transmitted electronically and then read by the surgeon, which is pretty cool. Um, One of the surgeons I work with is doing research right now, looking at artificial intelligence to read these reports, which is cool. So that's an option. A third option is a test called a CT colonogram or CT colonography. And that is a special CT that you take some gastrographin, which is an oral dye, and you drink it from the top end. So that outlines the colon, as well as the radiologist puts in some air through the rectum, and that air comes out black and the dye is white. So between those two things, they get a much better view of and then the air also helps to distend the bowel a bit. They get a much better view of the colon than on just a regular CT scan. And so they often get one of those three modalities to diagnose either an anemia or for suspicion of cancer. So positive stool test, iron deficiency anemia, altered bowel habits, especially diarrhea, loose stool that doesn't settle, and then also visible blood by the rectum, especially mixed in with the stool, is particularly suspicious. And the reason why I think is because hemorrhoids can cause bleeding, like fresh, bright red blood. So having like a bit of blood, like on the tissue paper, you have a bowel movement is less suspicious than like old dark blood that's all mixed in with your stool. But both require being worked up, as well as abdominal pain, bloating, and unintentional weight loss is another one. So a lot of the patients I see in my kind of cancer diagnostic clinics have sent by their primary care doctor with either changes to their bowels, blood in their bowels, a positive stool test, or iron deficiency anemia. And then based on how fit they are and based on how suspicious their symptoms are, then we do a history and exam and kind of triage them for what test would be most appropriate. And they run the range of colonoscopy is the most probably effective test, most likely to get a cancer diagnosis. It also has the benefit of being able to biopsy something at the time you see it. But it is the most invasive and does have a risk of a 1 in 1,000 risk of perforation, of making a hole in the bowel, but is the best for diagnosis. So while that's great, someone needs to be fit enough to have that, as well as be suspicious enough that you think there's going to be a cancer there to make it worth the risk. Whereas something like a CT colonogram would see a cancer if it's big. So something, if it's very suspicious, then maybe you would want to push for a colonoscopy if you could. But if someone isn't fit enough for a colonoscopy or even to do like the bowel prep for the colon capsule endoscopy, something like a CT colonogram still gives you a good answer without the risk of the colonoscopy. So part of my job as a PA is to do the initial history and physical and get all the information to determine what is the appropriate next step in investigation, and triage them to the appropriate test, undergo the appropriate test, and chase up on those results. And then when cancers are found, then send them to the surgeon to do their part. And so that's all part of the kind of collaborative care of a PA, of how, you're both using your skills as a clinician, but you're also helping your supervising physician by doing the kind of workup and straightforward. And then that's kind of, frees their time a bit to deal with the, very complicated things that need a surgeon's expertise on. And so that's a little about my professional life. So 40 minutes.
Well, first of all, thank you, Megan, for coming on here and taking the time to share more about your specialty, what it is to be a PA. We have a lot of pre-PA students who are really excited to hear from our PA speakers, and especially given your background, you've taken an interesting route where you work and also switching specialties. Really unique story to hear. And those cases, I learned a lot from those cases. I'm sure quite a few other students did too. Just to start off our questions, I wanted to ask, being in colorectal surgery, I'm sure that you have time set aside for procedures, but it sounds like by the way that you describe your cases, there's a bit of consulting involved too. I'm not sure if that's more involved than it would otherwise be in the US or not. I'm not sure if you would like to provide any perspective on that, that'd be great. But as you work in the UK, how much time is set aside for consulting versus procedure?
So I do one day a week in surgery, so all day, and I do 2 days in clinic. I actually have a very nice schedule for someone that works in surgery, because I do 4 10s Monday through Thursday, and today I was covering ambulatory emergency care, which is like urgent care for or like fast track ER for surgery reasons. So like people that have like suspicion of appendicitis, but it's not so suspicious. Then instead of going to like the surgery ward, they come to me. So unless I'm doing that, then I don't work Fridays or weekends, and that's very, very cushy for a surgery job. My other surgery jobs were not like that, but they do exist. So don't let that deter. Don't let just the schedule deter you if you're interested in surgery. So I do one day assisting in surgery. I do 2 days in clinic, And then I have a day that's on the ward and doing half a day is research projects. Um, and then I do like data sets on the surgeries that we're doing, as well as helping the surgeons with the research they're doing, like that AI research I mentioned. So that's a nice mix. And then I do the ward round every morning, and I think a helpful part of being a kind of standard member of the team is that I'm also able to um, spend maybe a bit more time with like the patients on the ward where the surgeons are incredibly busy and need to go, they have to be in surgery if they're being clinic. Um, and so it's nice to have a bit more time to um, develop a relationship with patients both in clinic and on the ward. And I also am often the person that like checks in on them like after hospitalization. So we call them a few days afterwards just to making sure they're fine. And I mean the surgeons would love to do that. They just, are being pulled in so many directions. So that's a nice part of my job that I enjoy. And I think it makes the surgeons feel a bit reassured as well, knowing that someone is, kind of checking out on their patients so they know they're okay when they're off doing their, surgeries and endoscopies and all the other stuff they do.
And knowing now that you eventually would work in the UK, if you look back and had to decide either by still doing, your undergrad and PA school in the US or doing it in the UK, which route would you have done? Would it have been easier to go through just PA school and all in the UK? And then
Well, I do think that PA programs are probably less competitive in the UK than, in the US it's incredibly competitive. Um, and but and obviously all of my students will be very familiar with the kind of debt that we get in American universities. Obviously, this doesn't benefit me, but undergraduate college in Scotland is free. Like, and in the UK, medicine is a 5-year bachelor's degree, like it is in a lot of other countries. So, like, doctors have zero debt, like not a dollar, which is like I mean, awesome, but like crazy to me because I mean, like 10 years ago, my brother graduated with like $300,000 in debt from medical school, and I'm sure it hasn't gotten better since then. So that's like, I mean, great for students in Scotland, but that's like crazy. And then I also feel like, oh, like you don't appreciate it. Not like if you have to pay $150,000 back. But it's a thing to consider because while USPAs can work in the UK as well as New Zealand, as well as Canada if you take their national exam, that's not always true for the reverse. So like UK PAs cannot practice in the US or Canada. So I probably would do the same, but I sure am jealous of these Scottish students and their lack of student loan debt. Um, but it all evens out. And because the UK is nationalized, you're kind of paid like a government employee, so the salaries are nothing like they would be in the US. So that is something to take into account as well for PAs and doctors.
yeah, definitely. And just in consideration of your specialty, when you made the switch to OB-GYN, or even before you decided on a certain specialty, even before you decided on OB-GYN as a PA, were there any other specialties that you were considering outside of OB-GYN and colorectal surgery?
Yeah, so I kind of fell into GYN oncology a bit. Um, I had done some work in OBGYN before PA school. My mom's a OB nurse and like a um nurse educator. Like she taught like the birthing classes where you like learn to breathe. Like that was like her, and I would go there a lot on weekends. And so I knew I liked OB/GYN and I was interested in learning. And I did a rotation, but my rotation was mainly obstetrics. I didn't get to see as much gynecology as I would have liked. And I knew I was interested in oncology, and as someone who um uh I don't know, maybe not I, I felt that my personality would be better suited for oncology than like being a trauma ER person. Um, and so I went to my school and asked, because we have a couple, we had two elective rotations that we could pick what we wanted to do. And so I asked if they had a gynecology elective or if they had an oncology elective, because those were two that I wanted to learn more about that I was interested in practicing. And they didn't have either as a general one, but they did have an elective in GYN oncology. So I said, okay, great. And and so I did it and I really liked it. It was like oncology care that was also women's health. And so I did my second elective with them as well. And then I worked with them when I graduated. And then I worked there for the 6 years till I moved to the UK. So I fell into it a bit. I think, but I really enjoy oncology and women's health and surgery. So it was a good combination of that. But I think I would have been very happy in a number of kind of surgical specialties. I kind of thought when I was working in general oncology, like, oh, like if I switch specialties, what would I switch to? And I thought that I would either do colorectal surgery, of course I ended up in, or maybe breast surgery, because that's also, you know, kind of women's health and surgery and cancer care. Um, and I would also tell the students, like when I was in school, my professors really encouraged us to work in primary care. And certainly, primary care is incredibly important and awesome. And if you want to go in primary care, that's fabulous. But if you don't want to go into primary care, I wouldn't feel like you needed to. Um, yes, maybe I have to study a bit more for my recertification exam than my friends that work in family medicine or ER, but it's one when I graduate once every 6 years. Now it's every once in every 10 years. So that's, I mean, that's not a lot to study. So if there's something that interests you, I wouldn't um feel bad about going directly into a specialty. I wouldn't feel like you're limiting yourself by doing that.
And earlier you mentioned how you were working with a physician um, doing some work in artificial intelligence. Is the research infrastructure in the UK similar to the US in that y'all have grants, or how would they otherwise be?
Yes. Yeah, there's grants. This one is National Institute of Health, which we, you know, use a lot in the US as well. Um and something that's slightly different is whereas in the US there are main academic centers and then just, you know, private hospitals that are non-academic. Like I always worked in a private hospital that did not have you know, residents or, you know, anyone in training. Um, but in the UK, kind of every hospital is a training academic hospital. So most of them are tied to a university, and so the university is also involved in a lot of the research stuff and have, you know, kind of funding. And so a lot of the surgeons are also um, like professors at the medical school universities that are kind of like affiliated with the hospitals. So I think they get, you know, funding that way as well.
All right. Well, another question I wanted to ask is earlier we talked about how you had an interest in psychology, which is why you ended up majoring in it. If you had not chosen PA as a career route, would you have been a clinical psychologist, or did you consider any of the other career
Yeah,
paths?
yeah. That was always my my plan to be a psychologist. And I wouldn't really be able to pinpoint when I switched. Now working, I think I would have been very happy as like a psychologist, as a counselor. But you know, um I'm happy with what I do now. Um I and I do think that's a thing that students can remember is, I think there's a lot of pressure on students to pick like the right career and, you know, don't mess it up because you'll never get the choice again. And one, there's always time, there's always chance to retrain and to switch. And also, um, there's probably lots of careers that you will be great at and that you'd be very happy in. So don't feel like, if you're choosing between two, that one's right and one's wrong. Could be that they're both right and they both will be great. Um, what Probably why I switched is, and maybe in retrospect doesn't make that much too much sense, but when I was in my psychology classes, my professors really discouraged us from getting a PhD to become psychologists, to become counselors. They're like, oh, it's like if you want to go in counseling, you should get a master's in social work. And um, and if you want to get a PhD, then you should go into research. And while I enjoyed doing a bit of research, I didn't want to dedicate my career to research. I wanted to work one-on-one with people. And it was around this same time that I was reading an article about rates of depression and suicide among uh, careers, and psychologists and psychiatrists were like second. I think dentists were first, and I was like, what is going on with dentists? But that made me think. That made me think as well. And then I thought maybe and I mean, because I mean we're friends here. I can be honest. I found out that the for how long you had to spend doing a PhD, the salary of a psychologist was also much less than I thought it would be. It was like 40,000 or something. Um, and I thought that's a long time in school to, um, I don't know, to maybe that's not like as much return on the investment of schooling I wanted. And the time I'd say maybe that's shallow, but I think finances are important. Um, and so yeah, so then I thought started that thinking that maybe I wanted to do something more hands-on with patients and more kind of direct than than either research or just counseling. And that's why I started to look more into like healthcare careers that were like direct patient care, where I could, do counseling and connecting with patients, but also kind of, get my hands dirty more. And so that's what kind of led me to my career change. I considered um, becoming a nurse midwife. I considered becoming a nurse practitioner, and then found the PA route. Also considered becoming a sonographer. There's lots of good career options, which is why I think these sessions are so great. So like maybe you can, find either specialties or careers that you hadn't thought about. There's a lot out there.
That is very true. There's quite a bit to consider out there. And that's great because different personalities have different preferences. So it's great that there's a variety out there. I wanted to ask just before we end off today's session with the few minutes that we have, if most of our students here are in the US, but having heard your experience, let's say someone might be interested in looking into, at least considering practicing in the UK, what steps could they take towards moving in that direction?
So USPAs can work in the UK. Your national certification allows you to work in the UK. Um, if you have right to work in the UK, it's very easy. You just like would apply for a job like anyone else. So if you have a spouse that's British, or you had a parent that's British, or something like that. Um, but it's not out of the realm of possibility at all to get a sponsored work visa to work in the UK. That's how I went over. And so to get that, you just need to be the, they just have to prove that you're more qualified than someone applying that doesn't need a visa. So a way to get that is by having experience in the area you're applying. So um, if I'm sorry, I just heard my earpods run out of battery. Can you still hear me?
Yeah, we can.
Okay, good. Good. And uh so if you're applying for an ER role, and if you've worked as a PA in the ER for 5 years in the US, that gives you a heads up, like a leg up kind of in the competition of being an experienced person applying. And so you'd be more likely to kind of get that role and be able to get a sponsored work visa to work in the UK. And there is a path, a recruiter, and they kind of specialize in American PAs who want to work in the UK. So that's something you could look into too if you're interested.
Well, I think that's for those interested, that's a great way to wrap up our session. This was definitely a great, unique session, I have to say. And I'm glad that we were able to have you on, Megan. I do have some reminders, though, for those who are listening in. Just before we wrap up, I have posted the quiz for today's session in the chat. That quiz is just a Google form, 10 questions, and you only need 6 or more correct in order to pass. And if you do pass, you'll receive a certificate just in recognition of your attendance today for the hour that we had. That certificate should be sent immediately to the inbox of the email address that you list on the quiz. If you have any trouble receiving it in your inbox, I would check your spam folder. And if it's not in either of those folders, please go ahead and email us. I have our email included in the video description of under the live stream here. For our next shadowing session, we'll be joined by Kali. She is a PA practicing internal medicine in Canada. So another PA,
Another international PA.
exactly, another international PA. What a coincidence. And we'll see her at 7 p.m. Central on Thursday, December 7th. Between then and now, we might have some shadowing sessions scheduled. And if we do, like always, we will be sure to post and update y'all with them on our Instagram or our listserv. Y'all will be in the loop through either of those. Those are great ways to stay tuned with us. One more thing, though, is our deadline. So that quiz, we do have deadlines for our quizzes, typically 6 to 7 days after the session, and that will be due. This one will be due on Sunday, November 26th at 11:59 p.m. Central Standard Time. So just be sure to wrap up with it by then. Before we do hop off, Megan, I know you have an Instagram handle. If you would like to share that for any students who would like to get in touch with you, that'd be much appreciated.
Yeah, great. Yes, yeah. You can find me on Instagram at expatpa, EXPATPA. And I post lots of videos about applying to PA school. I also talk about working in surgery, working in the UK. So yes, please. Go on.
We really appreciate it. A lot of students, like I said, our students are pre-PA. A lot of them are very eager to learn more about the field, and it's really helpful to have a guide to ask questions about that. But for those of you who are in America, I'm wishing you a happy Thanksgiving. And I hope y'all enjoy the rest of your week. But until then, we'll see you for the next virtual shouting session. And I hope y'all take care.